Welcome to the Athletes First Performance Podcast. This podcast is focused on providing evidence-based information for human performance and sports medicine professionals. All right, we're live. So welcome to episode 24 of the Athletes First Performance Podcast. Today we've got Griffin Zink, one of my friends and former colleagues. Griffin, welcome to the podcast. All right. So for those that don't know you, why don't you give us a little background of who you are, where you went to school, and so forth?
Yeah. So originally I'm from Cincinnati, Ohio. For undergrad, I went to University of Tampa my first year. I was going to play lacrosse. When that didn't work out, I transferred to University of South Carolina. Got a degree in exercise science there. Went back and forth between med school, PA school, PT school. Knew I needed to take a year off in between whatever I was doing. Found a job as a rehab tech at a bigger outpatient orthopedic clinic, and that's where you and I met, where you were a PT there. From there, I landed on PT and went to Ohio State for PT school, and then followed that up with an orthopedic residency at Body One in the University of Indianapolis.
Awesome. So what ultimately made you choose PT school over PA or medical school?
Well, I was studying for the MCAT, and I was getting burnt out doing that, so I knew that was a bad sign. But I always had an interest in fitness and sports, and so PT, being at that clinic with you guys, kind of made me realize like all my passions were kind of tied into one there. So ultimately, I ended up going that route.
Yeah, I know when you were a tech at where we previously worked, you were a huge help. That was a fast-paced clinic working with a lot of athletes. So I know I relied heavily on you and the other PTs. Definitely trusted you with our patients, and you did a great job there. So you went to residency. What residency did you go to, and why did you pursue that route?
So I went with an orthopedic one. Body One was the clinic I did all my clinical hours with, and then it was tied with the University of Indianapolis and their PT program. In PT school, went back and forth between sports and orthopedics. Ultimately, landed on orthopedics just because I wanted to go more the general route. Have a lot of variety in my skills and diagnosis that I would see. I didn't necessarily see myself being on the sideline for anything in my career, so felt like I should go the orthopedic route because there's a lot of overlap, as you know.
Oh yeah, definitely. I think any type of residency is huge, just like that structured mentorship, and it really makes you dive into the research and get a lot of feedback on your thought processes and the way that you do things as a clinician. So I recommend that for most young PTs, whether they're deciding for residency or not. So today our topic is the psychological readiness following like ACL reconstruction, especially that return to sport process. Where did that fit into your residency in regards to like performing that research project?
Yeah, so we'll talk about the article kind of at the end here, but really like how it happened for my process was the article happened first. So with or at Ohio State, they offer what's called the research specialization. I'd equate it somewhat to a minor, just not as many extra classes. But with that, coming from South Carolina, I did some research there. I knew I was interested in that. Ended up pursuing that at Ohio State, and they gave me a few options as far as topics on ACL rehab. I forget what the other couple were, but dealing with like biomechanics, landing mechanics, things like that. And it was just an opportunity for you to work on a project that was ongoing. But this one specifically that dealt with psychological readiness, one, I hadn't really heard a lot about it. You don't get a lot of information about that in school. I always thought psychology was interesting, especially in undergrad. And it gave me the freedom to pick some of the variables that we looked at. So there was a little bit more freedom there. So the whole time through school, I was working on that, and research takes a long time, so it carried over into my residency. In the residency, a research project was a component of that, and basically the guidelines were find a gap in clinical practice and do your best to go through the literature and find somewhat of an answer. And so doing that research specialization, working on that one specific project with Ohio State, I dove into the research with psychological readiness, and there's a lot of gaps. It's a newer thing that we're looking at. So I took that as my opportunity to spread out further from the actual project, and then try to tie some of those things together and come up with something based on what evidence we have as far as education, especially interpretation, as far as the ACL-RSI goes, which we'll talk about, and then potential treatment too.
Yeah, I think you hit the nail on the head there. There's a lot of gaps in that psychological readiness factor. I know myself included, I'm always looking at and reading the different physical performance side of ACL regarding like strength, power, reactive strength, things like that. But that's a huge part that's often forgotten, that psychological part. So I think reading your research project, one of the things that stood out is like, why should the psychological readiness be considered independent from like your strength and hop testing and those physical performance measures?
Yeah, I think that was kind of my clinical question going to my research specialization. I chose to look at quad strength and see how it related, because you would think quad strength is such an important part, especially with ACL rehab, and you would think if as that improves, the athlete's mindset would improve with it, just as physical function goes, and you're starting to do more, start return to sporting activities, things like that. But for the few articles that are out there, there really isn't a correlation with strength, and then even a few that are showing no correlation with hop testing either. So that just kind of highlights the importance that you can't assume that just because their quad is strong, they're hitting their biodex numbers, they're passing their hop testing, that psychologically, they're at a good point. I think that just, you think about the principle of specificity. Just because you're strong doesn't mean you're powerful. Just because you're passing all these tests doesn't mean you're back mentally ready to do whatever sporting activity that you're trying to get back to doing. Because a lot of these tests, there's pre-planned. It's not chaotic like in the sport environment, likely of where their injury actually happened. So when you think of it like that, it makes a little bit more sense of why it might not necessarily correlate.
Yeah, for sure. And what performance outcome are you using to check the psychological readiness?
So the ACL-RSI is the standard as far as assessing psychological readiness. It's used frequently throughout the literature. There are a few other outcome measures like the Tampa scale, but this is the main one, and it's specific to ACL rehab. There's also adaptations of it. I think one for FAI procedure, shoulder instability. So there's multiple adaptations of it now after seeing how well it's doing as far as the metrics go. But it's 12 items. They're ranked 0 to 100, with 100 being higher scores or higher readiness. And it's broken down into 3 different subscales. So you have emotions, which it highlights some of the commonly felt emotions as far as returning to sport, like anxiety, fear, things like that. You have confidence. So are you confident in your knee and being able to do what you were previously doing as far as getting back to sport? And then last one, risk appraisal. So risk appraisal, basically assessing the athlete's perceived risk of repeating the surgical process or repeating the rehab process too.
Okay. So at what time points do you have the athlete or your patient fill out that form?
There's nothing set in stone as far as what the research says. A lot of articles, kind of like the ACL rehab process in general, look at more time-based. So there's a lot of articles looking at that six-month mark and how it might impact potential return to sport or successful return to sport. There was one other article, especially with adolescent athletes, they looked at the overall change. So they took a RSI score prior to surgery and then at that 12-month mark, and they found that bigger change or a bigger change in that score over those 12 months resulted in better results as far as returning to sport. So a few different ways to look at it. I think it's important to get a baseline like all our other outcome measures. So whether that's during your prehab, before surgery, sometime around that point. I usually think about it at that 3 to 4 month mark. So when they're transitioning to that jogging program is usually a good time. Definitely the 6 month mark too, because with us at least, you're starting to do some plyometrics. So you're again transitioning into that next phase towards sport. And then it gets a little more vague at that point. I think we're going to talk a little bit about that return to sport continuum. but getting into that like 9 to 12 month mark, continuously doing that every time there's a next step made. So whether that's the transition from clinic to practice, practice to game, and then from there, it just gives you extra data points to show that overall change.
Yeah, I thought that was pretty cool. Just reading some of your research at that 6 month mark, a specific score may be predictive of future or a second re-tear. So definitely something to keep in mind. And also, can you talk about like that inverted U theory and how that plays a factor in the rehab?
Yeah, so one of the older theories that kind of reasons why this is an issue is the inverted U theory. The idea is that at the beginning of rehab, you have more negative emotions, which makes a lot of sense. Coming out of surgery, you're in pain, your knee's not moving as well, you're on crutches, you have a brace, life is not normal. And so then the argument is, as you transition, as you improve and heal, you get to that 3 to 4 month mark, you're feeling pretty good. You're off the crutches, off the brace, you're back to running, you're making a lot of progress quickly. And then it tends to invert, or can invert and go the other way too. So right around that 6 month mark, they argue that you start to see those same negative emotions, or you may see the same negative emotions. And what attributes to that is a little more, up in the air. A lot of it, I think, is now you're really getting back into sport activities that may have caused your injury in the first place. And so that might be where some of the tension anxiety is. Fear is reported as one of the biggest factors as far as athletes not returning to their sport. So that time period, you might see that shift where you would think from day one all the way to returning to sport, you might see more of a linear increase in that. But for some athletes, it might be the opposite.
Yeah, the first thing that I thought of when I was reading that is like at that 6, 7, 8 month mark, they're being exposed to harder tasks like plyometrics cutting, and they're like, oh wow, this feels a lot different than it used to, or they can actually notice the difference between their injured leg and their non-injured leg. So they're on that smooth path, they're running, jogging, they're feeling good, but then they get exposed to higher level demands like, oh wait, I'm not ready to get back to sport yet. And then those negative emotions start creeping in. So no, I thought that was interesting. Something that you sometimes see clinically, but you never really like put into words like what exactly is causing that.
Right.
So yeah, I thought that was pretty interesting to read. And then you mentioned the return to sport continuum. I think this is something that's continuing to grow in like the physical therapy field and return to sport process. But can you kind of explain what the new standard for a return to sport continuum is?
Yeah, so when I was doing my residency project and kind of developing that timeline of when you should assess, this was something I came across. So it was the Panther Symposium ACL Injury Return to Sport Consensus Group, and they published a consensus statement with 11 different statements. One of them actually being that psychological readiness should be assessed throughout the plan of care, which I thought was pretty powerful. The other one is they released a statement, or more like a graphic, to define a return to sport continuum rather than just a phrase. That seems to be one of the biggest issues in research, is what is the definition of that, and that might be a big reason why our return to sport rates are all over the place. So like I said, they made it more into a continuum. They broke it down into return to participation, return to sport, and return to performance. So return to participation being, think about like going back to practice or like a lower level of competition. Returning to sport is you're returning to your previous level, but maybe not at the frequency or intensity that you were previously. And then return to performance is you are 100% back. So with this, they also factor in not only a continuum, but they factor in the type of sport, so the level of cutting, that whatever aspects of that sport are involved. You factor in the frequency, so how often you're practicing, how often you need to be practicing, and then also the intensity too. So contact, non-contact, all that kind of plays a role, and I think it breaks it up nicely.
Yeah, and then just thinking about that return to sport continuum, do you have a framework on like specific milestones or checkpoints that the athlete should be able to hit before they move in from participation to sport and then ultimately performance? Do you have that mental model going for you?
As far as psychological readiness scores,
Yeah, psychological readiness or physical readiness. Like, is there anything that you saw in your research or just are doing clinically now?
with ACL-RSI scores, the interesting thing is it was validated in athletes that are older than 16. And so that 6-month mark that we talked about, one of the articles said there was a cutoff point. If you're higher than 62 out of 100, then it's likely that you're going to return to sport well. And if you're below 42, it might lead to a non-successful outcome. That doesn't necessarily reflect a younger athlete. And so there was another article that came out that specifically looked at athletes 12 to 20. It gave scores for a bunch of different outcome measures at that 5 to 7 month mark. And so it gave reference points. It was really, really helpful. It broke it down by gender and age, and then also ACL graph. So I use that as far as like a reference point. Again, that's at that 5 to 7 month mark. There's not enough research to show what score should be past that or closer to that return to sport phase. So it's hard to base it off of that. It's more just another piece to the clinical puzzle, and you got to use your clinical reasoning, I think, with everything involved as far as transitioning them from one phase to the other. But as far as that continuum goes, what I would say is assessing at each point there as they transition. And then what you're looking for is at least some level of increase with that. And then we'll get into a little bit of that of how sport exposure affects or may affect psychological readiness, which is one of the big points of my article. But if you don't see a positive response as they're getting into sport more and more, that'd be an area of concern for me.
Yeah, for sure. Yeah, we'll touch on that in a little bit. You previously talked about how age plays a role in RSI. What about gender? How does that influence RSI, and what are you seeing with that?
So that's another thing. Age we see a difference, and gender we also see a difference too. So kind of like ACL injury rates and return to sport rates, females tend to have worse scores, and that's fairly consistent through a lot of the articles that I've read. So worse scores, we're not sure as far as, like I just mentioned, as far as validity in a younger athletic population, what is a worse score, what's too low. One of the other articles that I found that was pretty interesting is they found no difference in ACL-RSI scores at 7 months between males and females, but they found it a little bit later in the process. So that I think it was around a 10-month mark. So another reason to be continuously checking and then following that inverted U theory that maybe it's not at that 6 to 7 month mark, it's further into that return to sport process as they get closer to being fully cleared. So especially for females, it may be more important to either extend the plan of care a little bit, be a little more cautious with you clearing them from return to sport phases in that continuum. But something that I thought was pretty interesting.
Yeah, and then that segues perfectly into my last point about your research. Like, what are the interventions that you utilize for athletes that are scoring lower or having a dip in their RSI as that plan of care continues?
I think that area of research is definitely the most scarce. There's not a whole lot on it, and so looking into it is pretty interesting. I think there's a lot of good ideas out there, but to say it's backed by robust research is not true at this stage. Some of like more simple ideas or recommendations I've seen definitely use to start with screening. So using the RSI, I think that's helpful, and it's really helpful in itself, especially if you start with that day one. If you read some of the questions, it just kind of opens up the door to, hey, this is a long process. 9 to 12 months is pretty daunting. It's going to be very physical. We're going to work a lot on getting your strength back and get you back to your sport. But there's also a huge mental side. We want to make sure you're psychologically ready too. And just saying that day one, I think is really powerful. Because if you get through that 6 to 7 month mark and you're concerned about that, I think that's a lot scarier to bring up to, a high school athlete unless you were, continuously through the process, checking in, making sure things were okay and keeping that communication open. So I think that's one more powerful thing. Definitely if it's a concern, look at in-session goals. So really short-term goals can help build up confidence in these athletes. And then some of the research has shown, and this is hard to do, but reducing extrinsic factors. There's a lot of theories about being more intrinsically motivated versus extrinsic. And I think that comes into that age, the age difference too. The extrinsic factors being, like, let's say it's an athlete on scholarship, so they have to get back to their sport, so their school's paid for. Or if they're a professional athlete, that's how they're feeding their family. More intrinsic, you're doing it more for you, you enjoy it more. And so that's where you get those older athletes. Maybe that is a bigger stressor that's put on them and affecting their rehab process. There's also a handful of studies that looked at visual imagery, cognitive-based therapy. And then one of the things I think is going to be really cool in the next couple of years coming out is more research on group training. So the effect of, especially in these periods where, like right now I have a kid, he's at 5 months, so like that 3 to 6 months where you're running, but you're really just continuing to hammer strength. Getting those kids in a group environment, strength training, I think can have a good effect. And I know there's some groups out there that are currently working on that and looking to see how that affects psychological readiness. But I think getting, especially athletes who are used to a team environment, getting them back with other kids who are going through the same thing. Now they're not as isolated. They're not just working with you in the clinic. They're seeing people who are more their peers, doing the same thing, going through the same stuff. So I think in future years, that's going to be some interesting research coming out.
Yeah, that was the one that caught my eye when I was reading some of your research, because the place where we previously worked together, that was a huge component of their process, right? In the afternoons, getting all those high school kids in there, working together as a group. And we try to group them together as close as we could in regards to how far along they were in the ACL process. And it was a lot of fun. It was hectic, but like a lot of those kids didn't know each other. And then they became best friends throughout the 4 or 5 months that they were rehabbing together. So yeah, that's huge. And I think a lot of big practices are starting to shift that route, just to get more kids through the door, and whether it be cash pay, insurance pay, things like that.
Yeah.
So yeah, I think that's definitely huge. And like you said, it's going to be becoming more popular in the physical therapy realm. Okay. So let's go ahead. Let's move into your research article, or like your article that was published in Sports Health. I thought it was an awesome article, and Sports Health is a great journal. So props to you for getting that published. So congrats, especially that early in your career. So that's awesome. So do you want to introduce the article and tell us about it?
Yeah. So like I mentioned earlier, this was my project through the research specialization at Ohio State. And so with that, you get on a project. The one requirement is you have to submit it to some kind of conference, and I submitted to CSM. I was fortunate enough that I got accepted, and so I was accepted to present rather than a poster presentation. So I got up in front of a lot of people, got out of my comfort zone, and did that. And then I actually had 3 months off between graduation and my residency, and my fellow authors asked if I wanted to push this through and make it a manuscript, and I thought it'd be a great opportunity. So we did that, and I spent my summer before residency doing that. So the official title is The Influence of Strength and Sport Exposure on Psychological Readiness After ACL Reconstruction. And kind of like how I talked about earlier, one of the factors I wanted to look at for sure was quad strength, just because of the role it plays in the rehab process and all the research surrounding it, just to see what the impact would be. But we had the unique opportunity. A lot of this data came from a time prime COVID. So we decided to add more of a measure of sport exposure to see how that affected it as well.
Oh yeah. So as I was reading through the paper, I thought for sure that quad strength would play a huge role in RSI. So can you describe like why you might think that quad strength is independent from RSI? And do you think if there was a measurement or test that was a little bit closer to sport, maybe like counter movement jumping, like single leg stuff, change of direction, do you think that would have a closer relation to the RSI?
Yeah, I think to answer the quad strength part first, I think every article I looked at that tried to relate the two measured quad strength somewhat differently. So for us, it was with a biodex, but it was isometric. So what would the difference be with like isokinetic strength? I think that'd be interesting to look at too. And then, all the other articles, like I said, had different methods as far as either relating it to isokinetic, isometric, or they used a different outcome measure. So basically, our article didn't find an association, but if you get more and more research out, that might change in years to come. There's just not enough to support it one way or the other. I think it'd be interesting to look at a more sport-specific movement. Like I said, there was one article that looked at hop testing and tried to associate there. They couldn't find it. But yeah, certainly I think that maybe something more closely related to that sport-related movement could have a better impact. Because good segue there. I mean, the big finding was with the sport exposure and how that positively influenced psychological readiness, or was related in our data set. And how we defined that was, this is a group of young athletes. They were cleared to return to sport, and this is within that first 8-week period. So the average time post-surgery was around 10 months for these groups. And sport exposure was somewhat loosely defined, just in general, how they attended practice or played in games at their previous level of participation. And so they found that the group that had much higher exposure to that had higher psychological readiness scores. And those who hadn't returned to sport, there's a variety of reasons. A lot of them, their season they just weren't in season. But a few of the other like extrinsic factors that I mentioned, like parents were concerned, they had fear of returning, a few like that stood out for that group. But it highlights the importance of getting athletes, one, maybe more into that continuum, so it's a broader or wider time frame to get them fully back to their sport, and two, getting them back to some level of being back with the team, or being back to that kind of sporting activity as quick as you can, while being safe after they've met all these milestones. But one of the inspirations actually for this article, I don't know if you remember him, but he's one of your patients when I was working with you. He was a lacrosse player. He had like a scholarship, I think, to a military academy.
Mm-hmm.
He was a senior.
Yeah.
And so I remember watching you work with him. I was also his coach at the time.
Yep. Okay. Yeah.
So,
yeah, I remember. Yeah.
So I just got to see that patient case from so many different angles, and I thought that was so interesting about how many other factors can affect the rehab process there and getting him back to sport, or getting athletes back to sport. So I saw what the impact was of him being able to get back into practice. Just like his mood was better. He was back with his team. He's isolated from the team, being on the sideline for so long. I saw what that did to him as his coach. So keeping that in mind as the therapist, I think it can be hard to think about the athlete's life outside of the 2 to 3 hours you get with them every week. But that, for me, that is a big takeaway from this whole project, is the importance of that.
Yeah, that's huge. And I think that's where it's super important to have good relationships, whether you're working with a lot of high school athletes, being able to work with athletic trainers, or have communication with the parents and coaches to be able to get them safely incorporated with the team, whether it be like if they're a football player, get them involved with like individual drills, maybe not contact or hard cutting, but just get them out there sooner rather than later so they can continue to build that confidence and just improve their overall psychological readiness like we've been talking about.
Yeah. I mean, that communication is super important, because that's, I think, the fear for a lot of PTs. If you send them back, that kind of opens the door for maybe some coaches and some teammates, peer pressure. If they see them out there, they think they're cleared to go. So that's where that, like you said, the communication between the whole team is critical if you're going to let them do some of that stuff and let go of the leash a little bit.
Yeah, for sure. So one of my last questions here. So what if an athlete is absolutely crushing it, like physically, they're strong, they've got their speed and power back, but their RSI scores are lower? Do you hold them back, and to what extent do you hold them back, and how long do you do that?
Yeah, I think that's a great question. I think it depends. A lot of the research looks at overall score, but it's really important, I think, to look at the subscale scores too. Um, just to recap, it's emotions. There's 5 questions to assess that. Confidence. There's 5 questions in that category, and then 2 for risk appraisal. So I'm looking for overall positive change in the RSI score from beginning to end. Hopefully that correlates with some of that stuff that they, like you just mentioned. But if, let's say, the score is being weighed down by their confidence subscale score, to me that's in our wheelhouse. That's, they're lacking confidence in their knee, their ability to do whatever they need to do for their sport, and that just opens the door again for that conversation. Well, what are you not confident in? What do we need to work on? And then maybe go back to do some of those in-session goals to build them back up to get to that point. Now, if it's in the motion subscale and that's the one that's weighing them down, that's when it's a little more towards that sports psych side, where maybe getting a sports psychologist or referring them out to them is going to be helpful, because I think that's a little bit out of our realm of practice if that's what's holding them back. As far as certain scores go, I don't think there's a score that I'll see that where I'm like, man, that's really low. I think I'm gonna have to hold you out for sport. It's more about the whole clinical picture. But like I said, I'm looking more at the subscales, emotions versus confidence. And then if one of those is weighing them down, I want to address that either through referral or through more specific rehab to get them back.
Yeah, no, that's awesome. Just like, did you see any type of research or any findings from what you're looking at in regards to what sports psychologists were recommending for these athletes or what they were providing for these athletes?
Yeah, I didn't see a whole lot. I think that's more separate. I did see, or when I was at the University of Louisville, I did a practicum there. I got to talk to one of the sports psychologists, which was interesting, but it seems like what they do is much different than anything that we would be qualified to do. So the problem with that is, I know it's maybe hard to find a referral, specifically there. I think they had 2 full-time staff for that for over 700 athletes, and the recommendation is, I think 1 per every 100 for NCAA athletes. And that's the same case everywhere I've been. It's harder to find that referral or to find that sports psychologist.
Yeah, and just having a team like athletic trainers, strength and conditioning coaches, PTs, mental performance, cognitive performance, I think we need to be able to refer out and collaborate just to help the patients or the athletes achieve whatever they want to. So, that's definitely a good point, making sure that we're branching out and reaching out to other health professionals to help these athletes. So, awesome stuff so far. Do you have any closing comments or any like other key takeaways from your research that you think the audience should know?
I don't think anything new. I think I just want to highlight again just the importance of communication, and then opening that door for athletes day one. Like I said, just because if it becomes a problem, you don't want to bring it up 6 months in and then add gas to that fire. It's something that should be started on day one and continue through the whole process. The importance of reassessing consistently. I think that ACL-RSI it's quick, it's easy, and it can provide a lot of insight to what your athlete is seeing. I think one of the other points is, it may not affect every athlete that walks in the door 100%. If you've been practicing for a couple of years now, you've probably gotten a kid all the way to sport from ACL and maybe not even brought some of this stuff up. But with how our rehab is and its question as far as the return to sport rates go, I think every little bit is important to know. So even if this might not impact your athlete currently, it might impact the next one. And really, I think it's pretty simple as far as just screening it right now and understanding that the RSI to the point where you can maybe make some clinical decisions about it. And I think that can be a powerful tool.
Yeah, that's huge. I know I'm definitely going to start incorporating this. This is not something that I usually incorporate. So
Mhm.
this is huge. This is definitely going to change the way that I practice and treat these athletes and patients. So appreciate all your research.
Yeah, absolutely.
Any future plans for research? Or are you done for right now?
I'm done for right now. I'd love to get back into it. Because I think the process was really fun. It's a long process, a lot of work, but I think it's really rewarding to get to the end, something like this and be able to contribute to our profession, especially this early on in my career. So yeah, definitely looking forward to eventually doing something. Don't know to what level that will be, but after the residency, taking OCS, take a little bit of a break now, but someday down the road.
Awesome. Well, I'll make sure to link this article in the show notes. And if anyone wants to get a hold of you or ask you any other questions, what's the best way to reach out?
I would just say by email. So my Gmail, Griffin Zink 1 @gmail. Would love to talk about any of the articles that we talked about or psychological readiness in general.
Perfect. So yeah, I'll make sure to put that in the show notes as well. So I really appreciate it. This has been a fun chat. Definitely learned a lot over the past couple days reading all of your stuff. So greatly appreciate it.
Yeah, absolutely. It's great talking to you. Great seeing you
Yeah,
again.
for sure. All right, take care.
All right, you too.
Thanks for listening to the Athlete's First Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website. Both links can be found in the show notes.